patients with overactive bladder have used pads for 3 to 5 years before they ever mention it to a doctor. So just making sure that we get the message out there, that people understand, that women understand that they just don't have to wait that long, that there are things that can help them.
Welcome back to the Bleedin Truth podcast. I'm Sally McNally, the Irish midwife, and I am so excited. Today I have managed to get Dr. Jill Hall on our podcast, and I'm going to tell you a little bit about this amazing woman. She's one of the most amazing women I've ever met. She's a board-certified obstetrician, gynecologist, and a fellow-trained urogynecologist, specialising in female pelvic medicine and reconstructive surgery. Yes, this is just what we need to talk about. Dr. Hall received her Bachelor of Science degree in Neuroscience at Brown University. She received her medical degree at the Keck School of Medicine, USC. She completed a residency in obstetrics and gynecology at UCLA and a fellowship in female pelvic medicine and reconstructive surgery at Long Beach Memorial Hospital with Dr. Donald Ostergard. Now, I don't know who he is, but I'm going to look him up. He sounds very important. Dr. Hall's clinical interests include the evaluation and treatment of urinary and fecal incontinence, pelvic organ prolapse, pelvic pain, sexual dysfunction. Dr. Hall performs minimally invasive surgeries, including robotic surgeries. And Dr. Hall chose to become a urogynecologist because she believes that being a woman should not have a result in health problems that keep us from living our best lives. She's passionate about educating her patients and treating them with the most up-to-date and evidence-based therapies available. She's a fellow of the American College of Obstetricians and Gynecology and a member of the American Urogynecologic Society. Wow, isn't that amazing? Aren't we lucky, girls? Thank you very much, Dr. Hall. Tell me a little bit why you feel you want to talk on our podcast today.
Oh, thanks, Sally. I'm happy to be here, and I think so highly of you, and so of course would do anything you ask me to.
You're so great.
So yeah, I'm just really pleased to get more information out there for women. I think pelvic floor disorders are something that are very, minimally talked about, even amongst women and female friends, and especially certain generations and the older generations of women just really don't talk about these problems to each other, and so end up feeling oftentimes very isolated and alone in their suffering. And so I think the more that we can put a voice and a face to, just how common these problems are, and really allow people to see that they're not alone.
Yes, thank you. That's so nice for women. While I was just sitting here waiting for you to come, I was thinking, oh, should I run and pee? Should I pee now? Should I hold it? I'll squeeze. And we are all like this. So many of us.
For sure.
So when I told my friends and some of my patients that I was going to talk to you, I asked them, what would you like me to ask her? And across the board, straight away, everyone says stress incontinence. Ask her, what am I going to do about this stress incontinence?
Yeah, well, that is one of the, very most common problems amongst women, and especially women who have ever born children, which is one of the biggest risk factors for stress incontinence. But stress incontinence, of all of the pelvic floor disorders, is one that can really be healed and fixed homeopathically, because the number one treatment for stress incontinence is strengthening of the pelvic floor. And I can't tell you how many patients come in and they're suffering from it, and they're like, well, I've done the Kegels, I've done them for years and years, and it just didn't work for me. But those very same patients, during the exam, when I have them do their Kegel, are not doing them correctly. I think that's a big factor. And I think we just really don't do a great job of teaching people how to do their Kegel exercises. And it takes a certain body awareness to be able to do it properly. So even people who are fit, who think, oh, I know how to do exercises, it's a totally different thing.
Ah.
So
I'm doing one right now while I'm
you
listening to
should
you.
be. You should be. I do them
And I'm
all
like,
day when
maybe
I'm
I'm doing it
explaining them.
wrong.
Yeah, so I always give some certain cues during the exam, and it's easier to tell if someone's doing it properly during a pelvic exam. But the cues that I give, first off, the most commonly misconceived thing is when you ask someone to do a Kegel, there is a certain amount of like abdominal valsalva that happens. So people push a little bit, like bear down.
Oh, yeah.
And so, really getting to understand the breathing techniques and the way that you can squeeze your pelvic floor without creating any increased abdominal pressure
Yeah.
is really important. So, I don't know, some people do yoga or Pilates, and in yoga, there is a certain, maybe you can tell us the proper name for it, but the certain kind of breathing where you take a deep breath and you breathe with your diaphragm. So you
Yes.
let your belly get,
Pranayama.
yes, thank you. So, letting your belly get soft and pushing your diaphragm down, and then using your abdominal muscles to then evacuate the air so that your abdominal muscles kind of suck in towards the spine.
Right.
And then in that position is when you really want to pull up on the pelvic floor. So you want to be evacuated from air and not have a breath in the diaphragm when you're pulling the pelvic floor up. Um,
Yes.
and so that's, I think, a hard, tricky thing for people to get the hang of. Um,
Yes. There's an advanced yoga breathing technique, and it's called Uddiyana Bandha, and it's
mhm.
like a lock. It's where we
The
lock
lock,
everything up.
yes.
And you
And
can't
that's
take a breath.
exactly
You got to be empty
right.
of air doing it.
Right. And that's
Yeah.
exactly how I try to teach people
Oh,
to
that's
do
amazing.
their
That's
Kegel.
great.
So,
Yeah.
in that sort of locked position, when you evacuate the air and then you suction in the
Mm,
abdomen, and
yes.
then you do your pelvic floor contraction.
Right.
So, then the cues that I give in that position, once the air is evacuated, and the abdominal rectus muscles are suctioned towards the spine, then I say, pull your vulva or your labia or your clitoris up to your belly button. So there's almost a little bit of a pelvic tilt,
Yeah.
and that does help people kind of understand and engage that sort of anterior low pelvic floor
I love
muscle.
that.
Um,
I love that. I totally get that. Yeah.
Yeah, that's how it really works the best. And I think when you do it that way, you can fix yourself. So about 40% of women can fix their stress incontinence with pelvic floor exercise alone. So it's a pretty significant number,
Yeah.
um, which, is important to know. And I think
Yeah.
that people give up on it maybe a little bit too soon. I think we wait too long to
Mhm.
engage the pelvic floor exercises. So,
Yeah.
in the Scandinavian countries, that women get a physical therapist that comes to their house for the first 3 months after childbirth to
Yeah.
help them do pelvic floor exercises. So,
Wow.
our patients aren't getting that.
Yeah.
They're on their own. A lot of the times they don't get sent to pelvic floor physical therapy
Yeah.
preventatively. So that could be,
Yeah.
something that our country really improves on. But taking matters into our own hands as women and starting to do the exercises after
Yes.
childbearing before there's a problem, I think would be
I think
quite
women are
helpful.
going to be really excited to hear you talking like this, because when they hear, oh, I'm going to talk to a doctor about these, they immediately think, oh, she's going to tell us all about the surgeries. But I'm so
Hmm. Hmm.
excited that you start here. This is
For
great
sure. Yeah. And I
because,
usually, um, especially in younger women, and by
yeah.
younger, I mean, 40s, 50s,
Mhm.
60s, I find that the younger you are, the more opportunity you have to
Yeah.
rehabilitate your pelvic floor.
Yes.
And so when you're in your 70s, even the surgeries don't work as well over
Yeah.
the age of 65. But the younger women, who are often the ones that are really most bothered significantly by the stress incontinence, are the ones who can rehabilitate the pelvic floor. So that's usually the first step.
Yeah.
And then the second step, if that fails, would be, potentially surgical management. Now, there are a lot of devices on the market. There's newer things coming out. The newest stress incontinence device is something called YoniFit, and it's kind of in appearance very similar to a menstrual cup, but it's a
Oh,
larger, longer menstrual cup. And
yeah.
so it goes in the vagina and it supports the bladder neck and
Mm.
helps with stress incontinence. So you can put it in when you go running or go to the gym or you go
Oh,
out dancing or whatever.
yeah.
So that would be a non-surgical option.
So is it similar to a pessary?
Kind of like a pessary, yeah, but
Ah,
a totally different model than has been available. It's a little bit softer, it's silicone,
ah.
and it comes with a self-fitting kit. So I think it's going to be something that's more easily accessible
Oh,
to
great. Yeah.
women without even having to necessarily. Right now, you do need a prescription for it, but I think eventually you might be able to get it over the counter.
It's
The other,
CVS.
yeah, CVS. The other over-the-counter option is something called Impressa. It's a tampon. So it's a stress incontinence tampon over the counter at the market. You can get it Target, CVS. You kind of have to shop around for that one. They don't always stock it, but
Yeah.
comes with different sizes, and then you just put that in the vagina,
Mm.
especially during certain activities that you find where you commonly have bothersome stress incontinence.
Like
And then
Zumba.
of course yeah, it's not for absorbing though. It's for actually putting mechanical support underneath the bladder neck. So
Okay. Yeah.
yeah, it's not absorbing the urine leakage. It's
Yeah.
lifting up on the bladder.
So going off on a wee tangent there, what if a woman has had a hysterectomy? Does that make any difference with lifting organs in the pelvis with these devices or
So sometimes with a hysterectomy, the main issue would be a shortened vagina. So your
Mm.
vagina can become shorter than it was. And so sometimes it's a little bit difficult to get a device that fits properly.
Okay. Yeah.
But they would still
Okay.
work. They would still work because the bladder neck is low. It's, your
Yeah.
urethra is about 3 to 4 centimeters. So your bladder neck is about 3 centimeters up the inside of from the
Okay.
outside of your vagina.
Yeah. And what about the fem ring
Hmm.
with like estrogen
So like the
creams and
estrogen, the E-string or Femring,
Mhm.
are estrogen replacement devices. And um, so those aren't really going to help so much with stress incontinence, but for the overall vaginal health in postmenopausal women,
Yeah.
they are very helpful.
Okay.
And so hormones, interestingly, for stress incontinence and for overactive bladder, the literature is kind of um, ambiguous, but most of the literature does point to worsening overactive bladder with systemic
Oh,
hormone replacement therapy. So, vaginal
wow.
estrogen,
Yeah.
yeah, interesting. Vaginal estrogen doesn't have that effect because it's not a systemic
Yeah.
effect, but the hormone replacement therapy in general, has there's mixed reviews in the literature, but most of the literature does point to a potential worsening of overactive bladder.
That's so interesting.
Mhm.
Gosh.
Yeah, yeah, you wouldn't think it.
That's
Um,
new. Yeah. Yeah.
so the ring is great for repleting estrogen, and many other pelvic floor disorders are related to a
Mhm.
depletion of estrogen, but not specifically incontinence.
What about medication other than estrogens? Or what about reducing things like coffee or alcohol? Any of
Yeah,
those?
so now you're getting more into a different kind of urinary incontinence, which is
Okay.
called overactive bladder. So
Okay. Yeah.
overactive bladder is characteristic of irritative bladder symptoms, so things like urgency and frequency of urination. And overactive bladder is characterized by urgency of urination, frequency of urination, leakage of urine with urge, and getting up at night to go to the bathroom. And so it is any of those irritative symptoms of the bladder, the urgency and the frequency, are signs that the bladder is irritated, and that can be caused by various things: infection, stone, incontinence, overactive bladder, your interstitial cystitis or painful bladder syndrome. All of these things have symptoms of urgency and frequency associated with them. So you kind of have to tease out that diagnosis a little bit. But things that irritate your bladder and specifically will worsen overactive bladder are coffee, tea, vinegar, citrus, alcohol, anything really acidic would be irritating to the bladder.
Right.
So overactive bladder patients certainly do want to avoid those things.
Yeah.
But overactive bladder is really interesting. It's like a neurologic, neuromuscular communication disruption.
Tell us more about that.
Yeah, so that's the thing that makes you, when you're nervous, think about, oh, should I go to the bathroom really quick before I leave, or should I go to the bathroom before I, maybe I should go to the bathroom before I leave the house, and maybe I should go to the bathroom since there's one right in front of me.
Even there's only like 3 cc's of urine.
Yeah, exactly. And then you go and you don't really have to go. So what happens with normal bladder function is that the bladder is a reservoir, right? It's supposed to fill, and you're not really supposed to be aware of it when it's filling. It's just supposed to quietly fill. And then when it gets full, it activates a little pressure sensor in the wall of the bladder, and that sends a feedback, initiates this feedback loop, right? So the brain then receives a signal from the pressure sensor, oh, the bladder's full. And the brain is consistently sending a neurologic signal down to the bladder muscle, which is like around the bladder. So it's kind of like a water balloon. That muscle squeezes and it squeezes the water out the balloon. Well, the urethral sphincter muscle is the opening of the balloon, and that's always trying to stay closed. And the bladder muscle is always trying to empty, right? So the brain inhibits the detrusor muscle or the bladder muscle consistently all the time. And when the brain gets the pressure sensor signal, it can release it. Then it starts thinking about trying to release inhibition of the detrusor muscle. So it's kind of always got to stop on that bladder muscle. Well, so then, you're thinking, well, I'm not in a socially convenient place to go to the bathroom. So you're kind of pausing the release of inhibition until you're on the toilet. And then you say, okay, I'm on the toilet, and the brain releases inhibition. The bladder muscle contracts, which causes the urethral muscle to relax, and then you empty your bladder.
Right. Yes.
So when you get overactive bladder, there's like a signal glitch, and you'll see that you'll have like subliminal cues will make you wet your pants, right? Because you think you see a bathroom or you hear the running water. That's always a famous one, right?
Yeah.
You turn on the shower, or you're about to get into the shower, or you're washing dishes. You touch the water, you put your key in the door, you're pulling in the driveway, anything that makes you associate with, oh, I usually go to the bathroom at this time, and you get an early release of inhibition and a leak. So it is a subliminal messaging that kind of triggers that. And so that's where like bladder training and urge suppression techniques and sort of cognitive behavioral therapy can improve overactive bladder. So I tell people, when you're going to do the thing that typically makes you leak, like put your key in the door or turn on the running water, Kegel first. And if you activate your pelvic floor muscles, the bladder muscle, the detrusor muscle cannot activate at the same time as your Kegel muscle. So that's the way Kegels can help with overactive bladder, is that they actually steal the nerve supply away from that spastic bladder muscle over to the pelvic floor, and the pelvic floor activates, and then that forces the bladder muscle to relax.
Love that. I love
Yeah,
that.
it's really cool. I mean,
Yeah.
we can see it on
Hmm.
urodynamic testing, and it's really great when during urodynamics, I can show patients they're
Yes.
having a bladder spasm and they start saying, I'm going to leak, I'm going to leak. And you can see the pressure of the bladder going up
Hmm.
because we have an electrode in there. And so you see the
Yeah.
pressure going up. And then I say, activate your pelvic floor. And we have an electrode on the pelvic floor. And so they do their Kegel, and you can see the Kegel start activating and the detrusor muscle start relaxing. It's just amazing.
Wow.
Yeah. So
It's
it's just really a
great.
fun technique.
And it's bringing the two worlds together, like that totally medicalized, um, futuristic, into a holistic way that
Mm-hmm.
she
Mm-hmm.
feels she has control then,
Right. Well, I mean,
before surgery or anything like that.
that's what you call biofeedback or cognitive
Yeah.
behavioral therapy, is like when you can see what's
Yes.
happening in your own body and
Right.
understand it
Yes.
and fix it yourself, and
Yes.
it's so empowering.
So great.
But it takes a level, Sally, of
Yeah.
belief
Hmm.
and willingness to try to understand, because one thing
Hmm.
that's so confusing for people is that they'll say, the feeling of urgency, the feeling of having to go is so
Yes.
powerful.
Yes.
It feels
Like you have no
overwhelming.
control. Yeah.
Yeah, it feels like you have no control. And so, there has to be an openness to being willing to understand, like, you're having a sensation.
Yeah.
It feels very convincing, but it's
Mm.
your bladder's telling you a lie, basically. Your bladder's
Yeah.
telling you it has to go when it's not all the way full.
Yes.
Um, and it's because of some other feature, that it's irritated from some food that you consumed, or,
Mhm.
you had a subliminal message that,
Yeah.
made it start
But
contracting early.
it's a different muscle. Like the heart, you don't have control over that kind of muscle.
Right. And you
But
don't
this.
have conscious control over your detrusor muscle either.
Yeah.
But you do have conscious control over your pelvic floor muscles. And
Yeah.
it's the fact that the pelvic floor muscles, if they're activated,
Mm.
can stop the detrusor
I love
from
it. We have to
contracting. Yeah.
become conscious in our pelvic floor,
Mm-hmm.
girls.
Mm-hmm. Yes.
So, girls, anybody listening to this, you can see why we send all our patients to Dr. Hall. This is so, so great. Um, so, what else now? What about fetal incontinence? Do you ever have to
Yeah.
deal with that? Is
Often,
that?
yes, I do. And it's more common than you would think. It's somewhere around like 7 to 9% of women. So,
Oh,
um, it can be exacerbated by like an obstetric, um, anal sphincter injury, but not always. It also comes about with weakness in the pelvic floor, as we age and lose
yeah,
pelvic floor muscle tone. So the first line treatment for that too is a non-invasive treatment, which is, stool bulking, we call it, with fiber. So like psyllium husk or Metamucil basically helps kind of form the stool a little bit more, make it bulkier. And the bulkier the stool, the earlier sensation of rectal fullness we get,
yeah.
and the more control we have over it. So that's kind of the primary, treatment goal for fecal incontinence. And again, a substantial number of patients can fix themselves with the,
Mhm.
stool bulking. Anal sphincter repair is one technique. It's fallen out of favor a little bit because,
Mhm.
by the time that you're in your 60s or 70s, when you're presenting with fecal incontinence, the chance that repairing the muscle is going to be functional is very low, because the nerve is also
Yeah.
probably lost. But that's one possibility. And then the other possibility is something called sacroneuromodulation, which is a nerve stimulator. And that's something I do quite often. Um, and that is an implanted device. It's an electrode that goes to your sacral nerve. And it comes with like a little pacemaker sized battery that gets put in your bottom. So in the, butt cheek, basically, you have like a little pacemaker battery. and it's about 85-90% effective at curing fecal incontinence.
Wow,
So
cool.
it again interacts with that like neuromuscular pathway, and that is also a treatment for overactive bladder. So patients who fail medication can move on for overactive bladder. If you can't train the bladder, then you try medications. And if you try medications and those don't work, then you can move on to what we call third line therapies, which are nerve stimulators or bladder Botox injections. So
Cool.
yeah, that device works for both fecal incontinence and overactive bladder.
Wow, that's amazing.
Yeah.
Um, Before we get on to the Botox for that area, um, women who suffer from fetal incontinence or urinary incontinence, could they be birth injuries? Could that have happened?
Um,
Weakened pelvic floors due to maybe multiple births?
so
Or,
all pelvic floor disorders are associated with childbirth, childbearing, and
Mhm.
childbirth do increase your chance of having pelvic floor disorders. Fecal incontinence specifically is associated with weakened pelvic floor muscles, but anybody can get weakened pelvic floor muscles. It's
Yeah.
not necessarily from childbirth. Same thing with overactive bladder. Anyone can get overactive bladder. It can be a woman who never gave birth.
Okay.
Um,
Yeah.
but if there's an anal sphincter injury, for example, during childbirth, that certainly can perpetuate the risk for fecal incontinence. And multiple births are associated more with stress incontinence, which is more of like a laxity of the pelvic floor that happens after multiple childbirths. Same with pelvic organ prolapse,
Yeah.
is higher risk with multiple vaginal births.
Right. And perhaps if we had been able to get to these ladies earlier and taught them how to do their Kegels correctly, um,
I think a lot of stress incontinence certainly could be avoided by Kegel
mhm,
exercises. And I think many of the symptoms from pelvic organ prolapse
yeah,
can be improved with um, pelvic floor exercise
yeah,
and physical therapy. Pelvic organ prolapse is thought to be more of kind of like a connective tissue disorder. So,
yeah.
kind of like a hernia. And so, um, can't always be repaired by exercise alone.
Okay, right. Wow, so interesting. I'm like, wow, my mind is going all sorts of ways. Um, we were just going to have a little chat there about Botox for the
Oh, so
vagina.
Botox is for overactive bladder, Botox
Okay.
in the bladder. So it goes in through the
Oh, in the
camera.
bladder. Yeah.
And that works to relax that spastic detrusor muscle. So when the muscle spasms and causes leakage without your control, the Botox kind of paralyzes that muscle
Yeah.
partially and so helps with control.
We see patients in the office who have recurrent UTIs.
Uh-huh.
And sometimes recurrent UTIs in pregnancy, and eventually we give them antibiotics, but then we're sending them over to you to
Mm-hmm, mm-hmm.
um,
So, unfortunately, as women, we have a short urethra. So we are at risk for urinary tract infection compared to men. So women get many more urinary tract infections than men do. And our urethra is centimeters away from our anus. So, whereas men have a much larger distance between those two areas.
yeah,
Um, so we just are prone to urinary tract infection, and most urinary tract infections are caused by the bacteria from the gastrointestinal tract. So you'd be surprised at how many women don't know or can't physically, like, can't
yeah.
seem to wipe from front to back.
Oh,
That is
yeah,
like one of the key
yeah.
features is that you have to wipe first, touching the urethra and then wiping towards the backside. You can't pull bacteria from the anus forward when you're wiping. If you're
Yes,
pulling from back to front, it's just a setup. So a lot of
right.
times people will get referred to me, and it's one of the first questions I ask, like, are
Yeah,
you wiping from the front side to the back side? And you'd
yes,
think everybody would know that, but they don't. It's not always taught. I mean, basically
Yeah.
your mom has to teach you that, or some girlfriend and
Right.
through the course of your life.
Yeah.
And so not all people are in that situation.
And also,
The,
sometimes they'll be wearing like a little G-string, just a tiny little,
hmm
a little like pathway, right? A little
Well,
that the
yeah, because it
bacteria can.
slides, it slides. It kind of slides towards the backside. And then if it
Yeah.
gets pulled a little bit towards the front,
Hmm.
it can introduce bacteria into the urethra.
Yeah. Yeah.
Um, and so anything that could be, spreading the bacteria, intercourse, sexual activity,
Hmm.
if there's any play that's happening towards the backside that
Yeah.
then pulls, attention to the backside before attention to the front side is not the
Right.
order that they should
Right.
go in. It should go in the
Yeah.
other order.
Yeah.
Um, and then sometimes there's just not any rhyme or reason, and people are like, well, I'm very clean. I wipe from front to back. I drink a lot
Yeah.
of water. I change my exercise clothes. I don't wear thongs anymore. And they're still getting infections. And it's,
Yeah.
there's various things that can contribute to that. Stones, abnormalities in the urinary tract. But the number one thing is postmenopausal women lose blood flow to the vagina. We lose our
Yeah.
estrogen.
Yeah.
The vagina becomes atrophic, and it's a setup for urinary tract infection. So all of a
Yeah.
sudden, the loss of blood flow causes a decrease in the pH or an increase in the pH, a decrease in the acidity, and that is a more hospitable environment for bacteria to grow.
Yeah.
And
Right.
so there's just more opportunity to get a urinary tract infection. So
Mhm.
my role is really, educating, trying to troubleshoot what's the cause. And if we determine that it's, you're postmenopausal and that's your risk factor and you don't have any other issues,
Yeah.
we replete the estrogen in the vagina
Yeah.
and usually start a cranberry supplement, which
Oh
is over
yeah.
the counter.
Hmm.
So there's an over-the-counter, multiple cranberry products out there, but what we're looking for is something called PAC, proanthocyanidin, and that's an ingredient that it actually blocks the receptors in your bladder wall where the E. coli cling to.
Oh yeah.
And so that's a really key, great, easy trick. Don't need a prescription for that. Can start taking that, and that will solve the problem. E. coli, once you get one E. coli infection, you're very high risk, 30-40% chance you're going to have another one in the next
Yeah.
3 months because it will
Yeah.
just, you'll take the treatment, and it will kill all the colonies. The antibiotics will kill,
Yeah.
all the colonies of the E. coli, but if there's a couple bugs that hang on to one of those receptors, they'll stick around and they'll repopulate, and
Yeah.
eventually that forms an infection. So the cranberry is great. Estrogen for postmenopausal women,
Yeah.
premenopausal women, or pregnant women, it's different. There are different risk factors, but pregnant women are typically immunocompromised, and so that's their risk factor.
Yeah.
Sometimes they have like a slower peristalsis of the ureters because of the progesterone effect. Everything moves a little slower. They get constipated. The bowels peristalse more slowly. The ureters are partially obstructed, and there's some backflow in the urinary tract because of the pressure of the fetal head and size of the fetus pressing on the ureters. So pregnant women have kind of different risk factors for UTI.
You're
Um,
so good at painting the picture. I see the picture in my head.
oh, good.
What
That's the
about
goal.
post-coital UTIs? So
That's a
having
good one.
UTIs after intercourse.
Very common. And, obviously the introduction of the bacteria up the urethra forcibly because there's an object getting, pushed into the vaginal opening and the urethra is right there. And so that object can then, being the penis, can then push bacteria up the urethra. And
Yeah.
so many women do have urinary tract infections that are resultant from the act of intercourse.
I
And
feel
so
so
it's,
sorry for those women who say, I don't want to make love to him because I know I'm going to get a UTI.
I
And
know, I
yeah,
know. The best thing to do for those people is just put them on an antibiotic with intercourse. And so I just give them a low dose antibiotic. They take it right before intercourse if they have any premonition. If not, they can take it as soon after as possible. And that really does the job.
Okay. So just after intercourse, take an antibiotic, just one, or
Yeah, so actually I prefer it before
okay.
intercourse. It works
Yeah.
better
Okay.
because it's
So
like
precoital.
precoital. Yeah, it's actually precoital is much better than postcoital, but
Okay.
um, historically it has been prescribed by many doctors postcoitally, but it works better if you take it before, 30 minutes before, just like prophylaxis for a surgical procedure.
Okay.
You kind of already have it on board. So, and for many of these women, it's they've been in a relationship for a long time, and it's like Tuesday night, that's the night. They know the time, they know the place, they can
Yeah.
take it right beforehand. And so that works.
Great. Well, I'm very old, Dr. Hall, and I've seen.
You are
I
not very old, Sally.
I have, but I've seen a few like really bad prolapses that I don't see here. So, I've seen like women with rectoceles like really bad, and I've
Mm-hmm.
seen. I remember seeing a woman when I was a young midwife, and we were doing this gynae clinic, and I thought it was a big tumor. I thought, oh gosh, she must have cancer, but it was her uterus had totally
Mm-hmm.
prolapsed,
Yeah.
and they were laughing at me, and I was like, no, look, the poor girl, there's something terrible. But they made it right, by a pessary. Just I saw it
Mm.
right away. So tell us a little bit about pelvic prolapses.
Okay.
What do you
So,
do?
pelvic organ prolapse is probably um, the bulk of what I do. So I'm surprised that you haven't seen a lot of it recently, but I see it all the time. It's
Yeah.
very common. And probably about 40% of women have an asymptomatic pelvic organ prolapse to a mild degree. So stage 2 prolapse is very common, and that is a prolapse that is like just inside the vagina or up to 1 centimeter protruding from the vaginal opening. And many times patients don't know they have that. It's not bothering them, it's not
Okay. Yeah.
symptomatic. So, really, when it gets to be stage 3 and 4 is when it becomes, more heavily symptomatic. And that means it's hanging out of the vagina further. Stage 4 is all the way out. And it can be anterior vaginal wall, posterior vaginal wall, or apical to the top, whether that's post hysterectomy and it's just the vaginal vault that's hanging out, or uterovaginal prolapse when the uterus is hanging out. So, yeah, so I always give patients the options. Pelvic organ prolapse is not dangerous. There are women walking around with stage 4 prolapse for years and years, and you just can't believe that they
Yeah.
put up with it for that long, but
Yeah.
they, just aren't bothered or don't want surgery, and they just
Mhm.
deal with it. So it feels like a big bulge hanging out of your vagina, and it's usually dynamic. So oftentimes it will go in when you're lying down, and then when you spend more time up on your feet and moving around, it will
Yeah. So
go back.
you do see prolapses that bad now, do you?
Oh, all
Yeah.
the time. Yeah.
Oh wow.
Yeah. Several, yeah, many
Yeah.
times a week. So, and then sometimes if it's hanging out super far and it doesn't go in and out, then it can cause some urinary obstruction and be more urgent. But typically it's not super urgent. And so I give people the choice, do you want to continue living with this? Do you want to try a pessary, which is like a vaginal support device that would push it back up in, and while it's in place, it should be comfortable and hold the prolapse up, and does have to get exchanged, taken out, and cleaned periodically, whether the patient does that herself or she comes into the office and we do it for her. And if patients are sexually active, I find that they're a little bit less inclined to use a pessary because it does have to come out for intercourse typically.
Mhm. Yeah.
Sometimes people can get away with having intercourse with the pessary in. It's kind of
Yeah.
a size dynamic. So if everything fits, then that's great. But
Yeah.
um, it doesn't always. It's kind of trial and error. I always tell people it's kind of like finding a perfect pair of jeans. Like you would
Yeah.
just have to try a couple different
Right.
sizes. So they'll try one and they might go home, and then they might have a bowel movement. It might come out, and and they'll go back and,
Yeah.
try another one. And so until we find the right model and size that fits and is comfortable. But many women love their pessary and use it for
Yeah.
years and years. And,
Wow.
there can be side effects of the pessary. It can cause discharge and some
Mm-hmm.
vaginal erosions. So like sores in the vaginal wall,
Mm-hmm.
which we typically try to prevent with vaginal estrogen cream, but those are the drawbacks and nothing dangerous. And then surgery. So surgery
Mm-hmm.
for different compartments is different. So, there you can have an anterior compartment, anterior cystocele repair. If that's the only facet of your prolapse is anterior. If it's apical prolapse, then there's robotic surgery to fix apical prolapse, and that's typically using either a ligament suspension, which is just suture, or a mesh graft, which is called a sacrocolpopexy.
Uh-huh.
Um, so those are surgeries that I do quite commonly. Same thing with the posterior compartment. If it's just the posterior, you can have a posterior repair, but oftentimes people have multiple compartment prolapses.
Wow. And how long would a surgery like that last? Like, how long would you be in there doing that? Is that very complicated? Is it?
So let's just say we're talking about uterovaginal prolapse, complete uterovaginal prolapse, I would usually do a hysterectomy along with a sacrocolpopexy, and that whole repair takes about 2.5 hours. And it's with or without a urinary incontinence procedure at the same time. So that can
Yeah.
change the timing a little bit, but we
Is
always
that
check
is that
for
a bladder lift? Is that what's called
um,
bladder
or
lift?
a sling
Sling. Yeah.
surgery.
Yeah.
Yeah. So we sometimes do multiple things all at once, but at the most it's 2.5, 3 hours, and
Yeah.
outpatient actually. So patients go home the same day
Yeah.
and
Wow.
go home with a catheter and come in the next day to have it removed, and 6-week recovery time.
That's amazing.
Hmm.
Amazing. Yeah.
Hmm.
I think I heard you saying, oh, she's going to need a hysterectomy. And then there was something about when would she have intercourse again? And
Hmm.
you're
Hmm.
like, she's not going to be having intercourse for quite a while. Tell tell us a little bit
So
about the
I
recovery.
think I think if I remember what we were talking about that time, I was talking about, we say 6 weeks for surgical recovery,
Yeah,
but really return to normal sexual function takes longer.
yeah,
And it's multifactorial. I think, at first there's just some fear and
hmm,
things feel different. It's uncomfortable. The muscles are sore. So
hmm,
I really try to tell people, you're looking at more like 10 to 12 weeks for normal return to sexual function.
yeah.
You go back to
Okay,
all your normal exercise and
yeah,
everything at 6 weeks, and you can have sex usually at six
hmm.
weeks, sometimes 8, but
But
it's
gently.
probably it's gentle. Yeah,
Yeah.
it's like, at first it doesn't feel the same. It takes a
Right.
little while for it to feel good again.
Okay.
Hmm.
Yeah. So another reason maybe to send these ladies to pelvic floor
Mm,
physiotherapy. We have
yes,
some great ones here in town.
we sure do.
Shout
Yeah.
out to Jen Evans there. She's
Yeah,
superb.
right.
So then there your surgical options. I'm sure you have more surgeries that you do. Um,
Yeah, so it just all depends on like the specific
yeah.
person and what their issue is.
Yeah.
But I do all of the different surgeries for pelvic organ prolapse: anterior repair, posterior repair,
Hmm.
vault suspension, ligament suspension, hysterectomy, sacrocolpopexy, all of the surgeries for incontinence, the sling, the Botox,
Yeah.
the sacroneuromodulation, the Bulkamid. We didn't talk about Bulkamid, which is another treatment for stress incontinence. And
Oh
this is
yeah.
a newer treatment. It's been out now for about 7 years, and it's an injection of a bulking material, like kind of
Oh
like
yeah.
filler that people use in their face, but it's for
Yeah.
the urethra. And that helps with stress, urinary incontinence, leakage with
Oh.
cough, sneeze, laugh. Typically, I do it in the operating room because it's uncomfortable. It's a needle poke in your urethra. But some patients do tolerate it in the office, and I have done it in the office for patients who prefer that. And it's no long term adverse events. So whereas with the mesh from a sling, you can have mesh erosions or complications, the Bulkamid doesn't have any of that.
Yeah.
The downfall is it only lasts for 7 years, so it does have to be sometimes repeated.
But seven
Um,
years is a long
but it's a
time.
pretty long time. Yep.
Yeah.
So
You
it's not
save quite a
ideal
lot of money
for
on pads.
sure. And it's not, probably ideal for younger women in their 30s,
Hmm.
40s, 50s, because those women will do really well with the sling, and the sling lasts for 25 years. So it's
Yeah.
probably better off for those patients to have a sling. But the patients over 60, 65 do really well with the Bulkamid. And like I said, some patients can't tolerate that in the office. So it can be a pretty easy,
Right.
quick fix.
Wow, that's great.
Hmm. Hmm.
So, do you ever get referred patients with sexual dysfunction?
Often. Hmm. Yep.
Yeah, yeah. And what would you do with, say, somebody who has pain during intercourse?
So pain during intercourse or pelvic pain can be complicated, right? Because there's so many different organ systems involved in the pelvis. You've got your urinary tract, you've got the vagina, you've got the reproductive organs, you've got the bowel, so yeah, and the pelvic
Mhm.
floor musculature and nerves. And then you can have referred pelvic pain from disc disease, spine disease that gives a referred pain into the pelvis. So you kind of have to rule out all of the different sources of pain. And pain with intercourse, can be complicated for that reason. But basically, I take it upon myself to evaluate each of those systems and see what the most likely contributor is to the pelvic pain. And a lot of that is based on physical exam. So young women who are still menstruating, the concern is, do they have some element of endometriosis? Is it uterine tenderness? Is it posterior uterine tenderness? Is it adnexal tenderness? Do they have a cyst or some kind of other pathology in the reproductive organs that's causing pain? Painful bladder syndrome can cause pelvic pain and painful intercourse, so we evaluate that. And then pelvic floor musculature. So oftentimes, one of the first line treatments for pelvic pain is also pelvic floor physical therapy. So definitely one of the things that I kind of wish every patient that got referred to me got sent to pelvic floor physical therapy first, because
Mhm.
um,
Okay.
it's nice to have them just kind of have done that and worked through some things,
Oh, yeah,
before
yeah.
we get started, as opposed to seeing me and then having to go do that for 3 months before we proceed with evaluation.
Will do. We'll all do that. Well, that's so interesting. So, is there anything else that you feel passionate about in your work? I mean, I'm lucky I get to work with you sometimes in your obstetrician role, and I get to
Hmm.
see the most amazing deliveries and sometimes C-sections, and um, you're like wonderful in every way there.
Oh,
So I
Sally.
don't get to see you in your other job, but is there anything else over there in your other job that you feel particularly passionate about, or you're like, this is my jam?
I mean, I guess I would say my two favorite surgeries to do are the robotic sacrocolpopexy, like pelvic floor repair, and the sacroneuromodulation. Mostly just because I see what an impact that has on people's quality of life afterwards. But no, my jam is really this, Sally. It's like just getting it out there and
Yeah.
making sure that people know that they can be helped
Mhm.
and that there are solutions and that they don't have to
Yeah.
live with these, I mean, by the time people come to
Mhm.
see me, they've been suffering with, wearing pads and incontinence and feeling yucky and,
Yeah.
having this discomfort for years.
Yeah.
And typically, any patient who gets referred to Urogyne, I mean, they've done studies on this, and patients with overactive bladder have used pads for 3 to 5 years before they ever mention it to a doctor. So just making sure that we get the message out there, that people
Yeah.
understand, that women understand that they just don't have to wait that long, that there are things that can help them. And
Yeah.
there isn't always a great fix for especially overactive bladder. Many patients with overactive bladder, like I can't make it go away all the way, but
Yeah.
I can improve it significantly. And so
Hmm.
that's always like kind of, important to paint like expectations
Yes.
properly, right? Like we're going to try really hard to make your quality of life better.
Yeah.
Um, but it might not be that
Yeah.
you can go without a liner or without a pad. Like,
Yeah. I love this. I love this so much because I'm a woman and I have these problems too. I mean, but
yeah,
I'll tell you, since we started having our chat, I haven't thought of my bladder once.
perfect.
And I
Yeah,
hope
you've got to distract.
all the girls who are listening to this, that they have this same feeling like, oh, okay, it's
Yeah,
not
urge
like a,
suppression. I
yeah,
say just like
mm,
do a Kegel, distract yourself, roll over, and go back to sleep.
that's brilliant. I'm going to
Yeah,
try that.
yeah. Like
I
only
have
get up once.
So I have rapid fire myths and facts to ask you.
Okay, okay.
Um, so true or false? Bladder leak is a normal part of aging.
Ooh, false. Not normal, but so common that it seems
Mhm.
normal,
Okay,
right?
right, but maybe
But
it's
not
not
normal.
normal. Okay,
Not normal.
great. True or false? Everyone should do Kegels.
True.
Yay! I'm doing
Even
one
men.
now. Let's do a communal
Let's
one,
do a
girls. Let's do it
communal
all
Kegel.
together. But
Even
let your
men,
breath
the
out
husbands
first.
should do the Kegels too.
Oh, yes, I'm always
I
telling
for
Johnny.
years there was no one doing sacral neuromodulation for men in this county, and so I was doing all of the fecal incontinence sacral neuromodulators for even the male patients, and the male
Oh,
patients, also need to do their Kegels.
yes. You hear that, you guys? Do your Kegels. Good for that prostate. Give it a good squeeze. True, true or false? Drinking less water helps urinary incontinence.
False.
Okay, don't dehydrate yourself.
Don't dehydrate yourself. It
Okay.
might, people do think, okay, well, if I drink less water, I'm not going to leak. And certainly, um, drinking your water at the right times is important. So if you're going to go out and about and you have urinary incontinence and you're afraid of a public accident, then it makes sense to not drink a big liter of water right before you go out. Um,
Yes.
but you have to drink water. You have to
Okay.
drink water.
Great. And then true or false? Prolapse always requires surgery,
False.
as we just discussed. And then true or false, recurrent UTIs are just something I have to live with.
False.
Are women talking about these issues more openly than they did in the past, do you think?
I think so. I
Yeah,
do think so. I think
yeah,
that the younger generations are really feeling empowered to take it upon themselves to make sure that they get answers and are asking more questions. And
yeah.
so I do think there is a change there
Yes,
for
I've
the better.
noticed it. The patients I get, like the older ones, they'll whisper to me,
Hmm.
I pee in my pants. Oh, and they're like, kind of like embarrassed to say it.
Yeah.
Or
Yeah.
they'll talk about lots of other things and then somewhere they'll just slip it in like, oh, and by the way,
Yeah.
and yet that's probably what they're coming in
What
with.
they're
That's,
actually bothered by.
yeah,
And more often, they will not talk about fecal incontinence. So they'll
right,
be,
yeah,
they're very shy about introducing bladder incontinence, and they're more shy. Most of the fecal incontinence patients go unnoticed. They
yeah,
do not tell their doctor. They won't say it. They might
yeah,
check a box on the form, but
yeah,
they're not going to say it out loud.
right. Um, what advice would you give to a woman who's embarrassed to seek help?
Don't be embarrassed.
Yeah,
We
because
see it
it's,
all the time. We
yeah,
see it all the time. We don't care. And
yeah,
and you can back me up on this, Sally. I mean, the patients are so sweet. They're like, "Oh, I didn't wash my feet, or I didn't get my nails done, or I didn't shave my legs, or I haven't had a bikini
yes,
wax, or I haven't taken a shower today. I don't
yeah,
think I want a pelvic exam." And it's like, I
yeah,
guess it's just that we've just done it so much that I
Right.
don't notice,
Yeah, I
it
know.
doesn't bother me.
We're dying to get in there and see what's the problem.
Yeah, we just want to help.
Did you like the way I was like,
Yeah, I like this.
what
Uh,
what symptoms should never be ignored?
Abnormal bleeding,
Oh,
blood
yes.
in the urine, blood in the stool, blood from the vagina at the wrong time or postmenopausal, abdominal pain, nausea, bloating, abnormal bowel movements. Um, those are the main ones, I would say.
Great. And so far now, in my mind, I'm thinking the steps that you've talked about, that you say, let's start with exercise. Let's give the
Mm-hmm,
woman a way to help fix herself if possible.
for
And that's
sure.
very empowering. I love that.
Mm-hmm,
And then maybe medication, maybe certain devices, and then finally, if nothing else works, surgery.
mm-hmm. Yep, exactly.
I think women will love to hear this because when they think, oh, I can't hold my urine, they think I'm going to need a surgery, and
Yeah,
they'll just rather live with the pads than that, some people.
right, right. Yep. Well, it's a choice. And I think knowing, urinary incontinence does need
Mhm.
to be evaluated because it needs to be proven that it's true, which kind of incontinence it is, and you don't have retention and there's not something else going on.
Yeah,
But typically, it's not dangerous. And so you get to choose, you should
yeah,
go here, discover which kind of
yeah,
incontinence it is and what there is to be done about it. But it's always in their hands. It's
mm,
always their choice. They don't
yeah,
have to do surgery. There's like a banquet of options, and
yeah,
they get to kind of choose what they want to do at
yeah.
what pace.
And then one last thing, I was wondering, when we're doing a vaginal birth, like I'm a midwife, and of course I'm all about the warm compresses and slowing it down at the end. Is there anything we should not be doing that you could advise us that could protect that pelvic floor?
I think you've heard me say it a bunch of times, but I'm not a huge fan of the whole laboring down situation.
Oh yeah,
Um,
yeah,
like if someone has an epidural and they're completely dilated, I don't want the pressure of that fetal head on the pelvic organs
okay,
for longer than it needs
yes.
to be. So I do like them to push, when they're dilated,
When they're complete,
um,
okay,
when they're complete. I think you do a lovely job of natural childbirth, and I think that's great. I think most patients, really want that. And I think just being cognizant of, we all are always trying to be aware of like, is this
yeah.
progressing properly? And
Not to push for six
not to push
hours.
for 6 hours.
Yeah,
Yeah. Yeah.
yeah.
Right, exactly. I think we, in this country, we have very few iatrogenic fistulas from
Mhm.
childbirth, but in third world countries, when the baby's head is stuck down there for hours and hours or days,
Yeah,
um, that patients do get fistulas. And I have, I've done a couple fistula repairs on obstetric
right.
fistulas this
Yeah,
year, even. So it is still something that happens when there's either a poorly healing, third or fourth degree laceration, or prolonged pushing and
yeah,
ischemia to the tissues. So obstetrics is not, without risk for sure.
yeah,
Um, but I think most of the time in this country, because we are careful about taking care of both mom and baby, that
yeah,
things go pretty well.
yeah. Fabulous.
Yeah.
Well, is there anything else you'd like to talk about? Is there anything else that
I think
when we're finished, we were
we've
like,
covered a lot
ah,
of ground. Yeah,
I
I'm sure there are
know.
things that will come
I
to mind, but
I
I
really,
mean, I
really
think
enjoyed this.
a whole other chapter would be, menopausal, perimenopausal symptoms. I think
Yes.
that's a hot topic right now,
Oh,
and
yes.
sexual function in the menopausal female. I
Yes.
think those are all like very important kind of hot topics. So we'll have to
Right.
maybe circle back one
To
day.
be continued.
Yeah. Very good.
Well, I am very grateful, and I always think of you as such a strong, wise woman, that you practice what you preach. You keep your own body strong and healthy. You exercise, you eat right, and like your
So do
parent,
you.
and
That's why
I
I admire
try.
you so much too. I want to
You,
be just like you, Sally.
oh, when you're an old woman. Well, I'm going to say again, thank you very much, and I know that this is going to help so many women. I'm going to get it out there, and I'm going to send it to my patients, and I'm going to play it wherever I can. And you ladies who are listening to this, please, if you're looking for a urogynecologist who's like really amazing, we have Dr. Hall here in Ventura County, and I'm going to post her information at the end of this podcast. Thanks a million, and
Thanks, Sally.
I hope we all listen, and thank you for joining me, Dr. Hall. I'll see you soon.
Thank you. See you soon.
So thanks again for listening. We really appreciate it. And if you like what we're doing, give us a bit of a review on Apple. That would help us so much. And if you come across a subscribe button, press the subscribe button. It doesn't cost you anything.